Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
For decades, textbooks, well-meaning general practitioners and, even seasoned surgeons have been explaining hemorrhoids to their patients as just simple varicose veins of the pelvis.
Right, yeah. It's a very neat, tidy explanation.
It is, but what if treating them like varicose veins is exactly why postoperative recurrence rates are so frustratingly high?
Yeah.
And, why so many patients just leave the clinic feeling like their problem was completely misunderstood.
Well, treating a hemorrhoid like a simple dilated vein, it fundamentally breaks the surgical mindset. I mean, if you approach this disease looking for some rogue varix to just simply tie off or strip away.
Like you would a saphenous vein in the leg or so.
Exactly, yeah. If you do that, you are missing the entire biomechanical architecture of the anal canal. You end up treating a symptom while completely ignoring the structural collapse that actually caused it.
Which is exactly why we are dedicating this deep dive to you. The surgeons, the registrars, and the doctors on the front lines who actually have to fix this issue in theater.
Yeah, it's so important to get this right.
Absolutely. So our mission today is to completely dismantle those outdated misconceptions around hemorrhoidal disease. We want to build a purely anatomy-first framework for choosing the right operative procedure and really synthesize the data into a rational clinical roadmap.
But before we unpack the anatomy and those algorithms, we really need to set a firm clinical guardrail.
Oh, right. Yes. Please note that this content is for reference only and that you must always follow local guidelines in your clinical practice.
That is a crucial baseline because honestly, the guidelines themselves have evolved significantly, as our understanding of pelvic floor histology has improved.
Right.
The literature over the last few decades has just aggressively dismantled that venous plexus myth.
Let's start right there, actually, with the anatomy and the pathophysiology, because, to understand how to fix the problem in theater, we first have to understand what this structure is actually supposed to do when it's perfectly healthy.
Right. Form follows function.
Exactly. And reading through the surgical text for this deep dive, a really brilliant analogy jumped out at me. We need to think of normal, healthy anal cushions, like the weather stripping around a heavy wooden door.
Oh, I like that.
Right. You have a door, the sphincter complex, that does the heavy lifting of keeping the exit closed. But a wooden door on its own isn't airtight.
No, it always has gaps.
Yeah, so to get a truly watertight, or, in this case, gas-tight and liquid-tight seal, you need that compressible weather stripping to fill the microscopic gaps.
That is a perfect way to visualize it. And that compressible tissue, it's located in three highly predictable anatomical spots.
The left lateral, right anterior, and right posterior positions, right?
Spot on. And the histological composition of that weather stripping is where the whole varix myth just completely falls apart.
Because it's not just a vein.
Exactly.
Yeah.
I mean, yes, these cushions do contain vascular sinusoids, which is why they bleed so profusely. But those vessels are heavily supported by an intricate matrix of fibroelastic connective tissue.
And smooth muscle, right?
Yes, the mucosal suspensory ligament. We often refer to it as the muscle of Treitz. So this is a dynamic, functional vascular cushion. It is not just a passive dilated vein.
Okay, right. And understanding that matrix of smooth muscle and connective tissue, that explains the actual pathophysiology of the disease?
That's purely mechanical.
Right. It's a mechanical failure of the suspension system over time. I mean, if a patient spends a decade dealing with chronic constipation, repeatedly generating massive downward intra-abdominal pressure,
They're putting immense shearing force on that connective tissue.
Exactly.
And then you add in the natural degradation of collagen and elastin that just, occurs with aging, or the profound pelvic floor relaxation and engorgement that happens during pregnancy.
So the system just wears out.
Over time, yeah. The mucosal suspension weakens, it stretches, the connective tissue matrix actually fragments. So the weather stripping begins to sag, descend, and eventually it just prolapses out of the anal canal entirely.
So the weather stripping is literally tearing away from the doorframe. Wow. And when we look at that structural descent, there is one crucial anatomical landmark that dictates, everything about how we perceive, classify, and ultimately treat this disease.
The dentate line.
The dentate line. It is the surgical equator of the pelvis.
It really is. The dentate line represents an embryological junction, and crossing it changes the entire innervation profile.
So above the line.
Right. So everything above the dentate line is internal hemorrhoidal tissue. It's lined by columnar mucosa, and it is supplied by visceral innervation from the inferior hypogastric plexus.
And visceral means no sharp pain.
Exactly. Because it's viscerally innervated, It is largely insensate to somatic pain. I mean, you can pinch it, band it, burn it. The patient will feel maybe pressure or discomfort, but not sharp pain.
But the moment you drop below that equator,
Below the dentate line, you are dealing with external hemorrhoidal tissue.
and that's totally different tissue.
Completely different. This area is covered by modified squamous epithelium, the anoderm, and it is supplied by somatic innervation via the inferior rectal nerve.
So it feels everything.
It is exquisitely pain sensitive. The density of nerve endings in the anoderm is incredibly high.
Okay, so let's look at this from the perspective of a frustrated patient sitting in your consulting room. A patient comes in, they've been told they have internal hemorrhoids, which we just established are above the dentate line and viscerally innervated.
Yeah.
Yet they are complaining of absolutely agonizing pain. I mean, how do we reconcile that anatomically if internal disease doesn't hurt?
It's a great question. And the answer is uncomplicated internal hemorrhoidal disease does not cause sharp pain.
So what does it cause?
The classic presentation of a purely internal prolapse is painless, bright red rectal bleeding, often dripping into the toilet bowl, along with mucus soiling, perianal irritation from that mucus, or a profound sense of incomplete evacuation.
Because the tissue falls into the anal canal, stimulates the sensory receptors, and tricks the brain into thinking there's stool waiting to be passed.
Exactly. A constant maddening tenesmus.
But no sharp pain.
No. Therefore, severe pain in a patient with a history of internal hemorrhoids is a massive clinical red flag.
It means something else is wrong.
Right. It points directly to a complication.
Yeah.
The prolapsed internal tissue may have become strangulated by the sphincter, leading to ischemia and necrosis.
Oh, wow.
Or, more commonly, a thrombosis has formed. Alternatively, the internal descent has dragged the highly innervated anoderm down with it, stretching those somatic nerve fibers to their breaking point.
So pain dictates that you are no longer dealing with just a simple, reducible internal cushion.
Exactly.
That is a phenomenal clinical discriminator. Pain equals complication, or it equals external somatic involvement.
Absolutely.
Now, since the core of uncomplicated disease is fundamentally about these cushions descending and prolapsing, how we systematically measure that descent dictates our entire operative algorithm, right?
Yes, the grading scale is everything.
Let's break that down.
So the grading of internal hemorrhoids is universally divided into 4 degrees. Grade 1 hemorrhoids bleed, and the blood vessels are congested, but there is absolutely no prolapse below the dentate line.
Okay, so bleeding only. What about grade 2?
Grade 2 hemorrhoids physically prolapse out of the anal canal with straining or defecation, but they reduce spontaneously once the straining stops.
They pop back in on their own.
Right. Grade 3 hemorrhoids prolapse and remain outside, requiring the patient to actually manually push them back inside.
So they have to use their hand.
Yes. And finally, grade 4 hemorrhoids are permanently prolapsed and completely irreducible.
You know, what stands out here, and I think this is a vital insight when you're planning your theater list, is that this isn't just some academic classification of tissue volume.
No, not at all.
Like, a massive grade 2 that spontaneously reduces is a fundamentally different surgical problem than a tiny grade 3 that requires manual reduction. The grading is entirely behavioral.
Exactly. It measures the absolute mechanical failure of those suspensory ligaments we talked about earlier. The ligaments in a grade 3 have lost all spontaneous recoil.
Right.
And that behavioral grading, it governs your clinical thresholds. Isolated bleeding in grades 1 and 2 dictates that you generally stay out of the formal operating theater.
You manage those non-operatively.
Right. Aggressive bowel regulation, fiber supplementation, or simple in-office procedures.
But when you operate,
As that prolapse becomes manual or irreducible in grades 3 and 4, or if you identify a significant symptomatic external component, the patient crosses the operative threshold.
Okay, so let's explore the actual tools in the surgeon's arsenal, contrasting those first-line office fixes with the heavy hitters of traditional surgery.
Good idea.
For early-stage disease, grade 1, grade 2, and highly selected grade 3 rubber band ligation is heavily favored in the literature. But how does putting a tiny rubber band on a mucosal cushion actually fix the underlying mechanical failure of the ligaments?
Well, the mechanism of rubber band ligation is actually quite elegant in its simplicity. By deploying a tight rubber band at the base of the internal mucosal cushion, you immediately choke off its blood supply.
Which induces localized ischemic necrosis.
Exactly. Over the next 7 to 10 days, that strangulated tissue sloughs off. But the real magic happens during the healing phase.
The scarring, right.
Yes, the resulting mucosal ulcer heals with a dense fibrotic scar. That fibrosis acts as a biological pexy. It firmly tethers the submucosa back to the underlying internal sphincter muscle.
So it's essentially pulling the sagging weather, stripping back up, and locking it into place.
That's exactly what it does.
It's an internal lift achieved through controlled scarring. But there is an absolute, non-negotiable anatomical rule for anyone performing this, isn't there?
Oh, absolutely. The band must be deployed at least 1 to 2 centimeters above the dentate line.
Because if you don't...
If you misjudge your anatomy and capture any of the somatically innervated transitional zone or anoderm in that band, the patient will immediately jump off the table in agonizing pain.
They will scream.
Yes. And you also run the risk of causing a severe vagal response. Bradycardia and hypotension, just from the sheer intensity of the somatic pain.
That sounds terrifying. Now, as an alternative to banding, the sources do discuss injection sclerotherapy, right? Where an agent like phenol in almond oil is injected into the submucosal space to induce a similar fibrotic reaction.
Sclerotherapy is an option.
It seems appealing for small, friable internal hemorrhoids that might be, too flat to easily draw into a band ligator. But structurally, it doesn't seem to offer the same robust mechanical lift as the ischemic sloughing of a band.
And the data reflects that. Recurrence rates tend to be higher with sclerotherapy compared to banding, particularly for anything beyond a mild grade 1.
Makes sense.
And neither banding nor sclerotherapy will do absolutely anything for substantial external disease. You cannot inject or band the pain-sensitive anoderm.
Which means when office procedures fail, or when a patient presents with advanced grade 3 or grade 4 disease with bulky external skin tag components, we have to move to the conventional excisional hemorrhoidectomy.
The heavy hitter.
Exactly. This is universally acknowledged as the most durable, definitive operation, giving the lowest long-term recurrence rates.
The principle of excisional surgery is really straightforward. You use diathermy, scissors, or an energy device to physically dissect and excise the diseased, prolapsing hemorrhoidal columns right off the underlying internal anal sphincter.
And there are 2 main ways to do this surgically, right?
Yeah, the 2 classic approaches are the open Milligan-Morgan technique, where the mucosal and anodermal excision wounds are left open to heal by secondary intention.
Okay, and the other one?
And the closed Ferguson technique, where the surgical defects are meticulously sutured closed.
So sorry for the interruption, but this is important. We need your support to help us grow, reach more surgeons, and keep delivering cutting-edge surgical content. Press the support button and donate now if you like what we do. Let's get back to the podcast.
I know surgical dogma can be quite fierce regarding open versus closed, but looking at the meta-analyses from our sources, there isn't a massive daylight between the two in terms of ultimate safety or long-term efficacy.
No, not really.
The closed Ferguson heals slightly faster if the sutures hold, while the open Milligan-Morgan avoids the risk of trapping infection under a closed wound, and, well, it's technically faster to perform.
That's a fair assessment.
But both approaches come with a massive, undeniable trade-off. The postoperative pain is notoriously brutal.
Oh, it's awful. You are deliberately carving into one of the most richly innervated areas of the human body.
Right.
The early postoperative period requires aggressive multimodal analgesia, topical nitrates or calcium channel blockers to reduce sphincter spasm, and meticulous bowel softening.
But the pain isn't the only risk, is it?
No. The true art of the excisional hemorrhoidectomy is knowing when to stop cutting. You must preserve adequate, healthy mucosal and anodermal bridges between your excision sites.
Because if you don't, you induce anal stenosis.
Exactly.
And let's think about what that actually means mechanically for the patient. If a surgeon gets overzealous and excises too much circumferential tissue, the resulting circular scar contracts as it heals.
Right, and it shrinks the opening.
You turn a compliant, dynamic anal canal into a rigid, fibrotic ring.
It's terrible.
The patient then suffers from outlet obstruction, chronic straining, and painful fissures every single time they try to pass a normal caliber stool. It is a devastating iatrogenic complication.
It really is. Reversing a severe anal stenosis requires complex advancement flaps and offers absolutely no guarantee of restoring normal compliance.
So less is more.
Overexcision is the absolute enemy in this operation. Leave the minor secondary hemorrhoidal vessels alone. Focus only on the dominant pathological pedicles.
Now, because conventional excision is so historically painful and fraught with the risk of stenosis, it really drove a massive wave of surgical innovation over the last few decades.
Oh, definitely. Surgeons sought ways to fix the prolapse without taking a scalpel to that highly sensitive anoderm.
Which brings us to the modern tissue-preserving alternatives, stapling and arterial ligation.
The surgical goal really shifted toward finding a durable fix with minimal somatic pain.
The analogy that perfectly encapsulates this shift is home repair. A conventional excisional hemorrhoidectomy is like tearing down the drywall in your living room to fix a sagging ceiling.
That's a great way to put it.
Right. It is destructive, it hurts, it takes weeks to plaster and paint, but when it's done, the problem is definitively gone.
But the newer techniques...
These newer techniques are like sneaking up into the attic, pulling the ceiling up from the rafters, securing it from the inside, and never leaving a single scratch on the living room walls.
I love that. Let's examine stapled hemorrhoidopexy through that lens.
Yeah.
This is a mucosal resection and a flocculation procedure performed entirely in the quote-unquote attic above the dentate line.
Right.
Using a specially designed circular stapler, the surgeon removes a circumferential ring of redundant rectal mucosa and submucosa.
Crucially, you aren't actually cutting out the hemorrhoids themselves. You are operating geographically upstream of the problem.
Exactly. When you fire that stapler and remove the tissue ring, the titanium staples bring the cut edges together.
And that achieves two things, mechanically.
Yes. First, it physically hoists the prolapsing hemorrhoidal cushions back up into their normal anatomical position within the anal canal. Second, the staple line transects the terminal branches of the superior rectal artery.
Interrupting the vascular inflow that keeps those cushions engorged.
Exactly. And because the entire staple line is deployed in the insensate visceral zone, patients experience drastically less pain and return to work much faster.
But there is a biological cost to stapling blindly inside the rectum. I mean, if you take too shallow of a bite, the staple line tears, and you get massive hemorrhage.
That's true.
If you take too deep of a bite and incorporate the full thickness of the muscularis propria, or heaven forbid, the vaginal wall, you are looking at devastating complications.
Yeah, the unique complication profile of the stapler includes severe urgency, chronic staple line pain, and rare but catastrophic pelvic sepsis or rectovaginal fistulas.
Wow.
Furthermore, long-term data shows a statistically significant higher rate of recurrent prolapse compared to excisional surgery.
Okay, so if stapling carries the risk of rectal wall damage and staple line complications, you'd logically want a way to stop the bleeding without firing a titanium ring into the gut.
Right.
And that points us to Doppler-guided transanal hemorrhoidal dearterialization, or THD.
Yes, THD.
You use a proctoscope with a built-in Doppler ultrasound probe to precisely locate the terminal arterial branches feeding the plexus. Once you hear the pulsatile signal, you place a figure-of-8 suture to ligate the vessel.
You shut off the high-pressure arterial inflow, causing the cushion to shrink over the coming weeks.
But tying off the artery only fixes the bleeding component. I mean, if the tissue is already sagging to a manual grade 3, just stopping the blood flow doesn't mechanically pull the weather stripping back up.
No, it doesn't.
The ligaments are still broken. You have to physically tether it somehow.
Which is why the dearterialization is almost always combined with a mucopexy. After ligating the artery, the surgeon runs a continuous suture down the length of the prolapsing mucosa, stopping just proximal to the dentate line. When that suture is tied tight, it pleats the mucosa and physically hoists the prolapsed tissue back into the canal.
That's clever.
It is an excellent pain-sparing operation, but again, it shares the same drawback as the stapler, higher long-term recurrence rates than traditional excision.
Right. So these non-excisional techniques are basically trading early post-operative comfort for a slightly higher risk of needing another procedure 5 or 10 years down the line.
Essentially, yes.
Which brings us to the most practical part of our deep dive, the theater pearls. We have the bands, the scalpel, the stapler, and the Doppler on the table. How does the operating surgeon synthesize this, make the final call, and avoid a disastrous outcome?
The algorithm dictates matching the technique strictly to the specific anatomical defect.
Okay, break that down.
If the patient has predominantly bleeding internal hemorrhoids without major descent, you lean toward banding or arterial ligation. If the patient has prolapsing internal hemorrhoids, you consider the stapler or arterial ligation with a mucopexy.
And for mixed disease.
If the patient has mixed internal-external disease or massive fibrotic external skin tags that interfere with hygiene, you really must proceed to an excisional hemorrhoidectomy.
Yet, we all know patients who bounce back to the clinic 3 months post-op, furious because they feel the surgery failed. I mean, if the algorithmic choices are so clear-cut, why do these early failures happen so frequently?
Honestly, early failure usually stems from incomplete procedure selection, not poor tissue healing.
Interesting.
The most common trap is trying to force a tissue-preserving technique on the wrong anatomy. A surgeon might use a stapler or a Doppler ligation on a patient who has a massive external component.
Right.
The stapler fixes the internal prolapse beautifully, but the patient wakes up with the exact same painful external lumps they had before surgery.
Oh.
From their perspective, the operation was a total failure.
Because you left the most bothersome part of their disease completely untreated just because you were trying to spare them the pain of an excision.
Exactly. And we also see catastrophic failures due to inadequate postoperative care.
Like what?
Well, the sheer mechanical force of a rock-hard, constipated stool against a fresh hemorrhoidectomy wound or a delicate new mucosal pexy will physically tear the repair apart.
That's brutal.
Patients are terrified to defecate after anal surgery, so they hold it in, the stool desiccates, and they become impacted.
A completely preventable mechanical disaster. So for the surgeon doing their preoperative workup, it means you cannot plan your operation based on a vague 5-minute history.
Never.
A thorough, unhurried examination and rigorous endoscopy in the clinic are absolutely vital. You must map the disease internal versus external, bleeding versus prolapse, before the patient ever goes to sleep.
An accurate preoperative map is the only way to tailor the intervention to the anatomy.
Absolutely. Well, as we wrap up this deep dive, I want to leave you with a final, forward-looking thought to mull over on your own. We've established that hemorrhoidal disease is fundamentally a mechanical disorder of pelvic floor pressure and tissue prolapse.
Right.
But look at where global medicine is heading right now. We are witnessing an absolute explosion in the use of GLP-1 agonists for massive weight loss.
Oh, that's an interesting point.
These drugs fundamentally alter gastrointestinal motility and transit times, often causing significant constipation, while simultaneously stripping away visceral and pelvic fat.
Which changes the whole pelvic floor dynamic.
Exactly. Are we about to see a fundamental shift in the sheer volume and presentation of hemorrhoidal disease in the next decade?
It's very possible.
Will the rapid changes in pelvic floor fat pads and the altered bowel mechanics driven by these medications create an entirely new epidemic of connective tissue shear and mucosal prolapse?
The structural anatomy of the anal cushions won't change, but the forces acting on them definitely will.
The metabolic and mechanical forces acting upon them are shifting beneath our feet. It is a fascinating space to watch. Well, if you found this Anatomy First framework helpful, please don't forget to share this deep dive with at least one of your colleagues or friends to spread the word. We really rely on your word of mouth to keep this going.
Definitely.
Also, be sure to check out our YouTube channel and our other social media pages for visual breakdowns of these concepts.
And if you are looking for more surgical frameworks, do check our previous season and deep dives, which features some very relevant topics on complex pelvic floor management.
As you head back to the wards, the clinic, or the theater, remember that opening contrast. We aren't just setting a broken bone, we are managing a dynamic, living, highly innervated plumbing system.
It's all about respecting the anatomy.
But when you approach it with an anatomy-first mindset, you realize that managing hemorrhoids doesn't have to be muddy waters after all. It can be just as elegant and just as precise as any other field of surgery. Thanks for joining us on this deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.